Hey everyone, think for a moment about how we talk about feeling, down, stressed, maybe just not quite ourselves.
hmm
Have you ever stopped to wonder if maybe we're increasingly seeing these really normal human experiences as, well, medical problems?
It's a really common thing now, isn't it?
It is, and today we're taking a deep dive into exactly that,
Yeah.
this growing trend of um, medicalizing human unhappiness.
Yeah, and our main guide for this exploration is a really compelling piece called Demedicalizing Misery too. But we're also drawing on a bunch of other insightful stuff.
Right. And our goal here, our mission, if you like,
Yeah.
is to really unpack this idea, this notion that so many of life's difficulties are being framed as like brain problems that need a medical fix.
Exactly. We want to look beyond just the biology, and think about other ways we might understand human suffering, alternative perspectives.
And we've got a really wide range of views we're bringing in today, everything from detailed academic work to some pretty critical takes on the mental health industry and even some personal stories.
Yeah, it's a good mix.
Okay, so let's just get right into it. Where does this really start, this increasing focus on the medical side of unhappiness?
Well, a huge piece of it is what some people call the rise of the neurochemical self.
The neurochemical self.
Okay. It's this cultural push almost encouraging us to see our difficulties, anxieties, feeling low, trouble focusing as basically problems with our brain chemistry.
Uh,
Think about all those online quizzes like, are you bipolar?
well,
Or mood diaries. They subtly push this idea that your feelings, even just normal ups and downs, might be symptoms of a brain malfunction.
like we're being told to think of ourselves as just, I don't know, a bag of chemicals that can get unbalanced.
Pretty much. And this way of thinking, it's actually evolved quite a bit over time. Demedicalizing misery, too, points out some really interesting shifts.
Oh, yeah. Like what?
Well, back in the 80s, say, if someone was really struggling with worry and pressure, it might have been framed as anxiety and stress, maybe linked to their environment, right?
Okay, external factors.
Exactly. And maybe they'd get benzodiazepines, to manage the immediate feelings. But the focus was often on those external pressures.
Right.
Then you get to the 90s, and the story changes. It becomes much more about chemical imbalances in the brain. Depression gets linked to low serotonin, supposedly fixable with Prozac.
Ah, the Prozac era.
So we sort of shifted from blaming the environment, or at least seeing it as a major factor, to blaming the brain itself. And sometimes we lose sight of how those two interact.
So the focus went inward to something that sounds very scientific, very concrete brain chemistry.
Right.
But the authors of Demedicalizing Misery 2 raise a really critical point here. What are the downsides? What happens when we mainly see unhappiness as a brain issue?
Well, the big worry is that this medical lens can kind of overshadow the very real social stuff, the circumstances in people's lives that are making them unhappy.
Okay.
If the problem is just in your head, quote unquote, it can make people feel pretty powerless, right? They can't change the external situations that might actually be the root cause of their distress.
Yeah, it could lead to a feeling of resignation, maybe,
Yeah.
instead of feeling empowered to tackle those issues.
Exactly. And that leads us into some really fundamental questions about psychiatric diagnoses themselves. Demedicalizing misery, too, definitely doesn't hold back on the critiques here.
What kind of critiques are we talking about?
Well, one fascinating point is the lack of objective, measurable signs in psychiatry. Unlike a lot of medicine where you have a blood test or a scan.
Right, something definitive.
Yeah. Many psychiatric diagnoses rely heavily on subjective reports, what people say they think and feel, how they behave. And the book points out this risk of circular logic.
Circular logic. How so?
Like saying someone hears voices because they have schizophrenia, the label becomes the explanation, but it doesn't actually explain the mechanism behind the voices.
Gotcha. So the label describes the symptoms, but doesn't necessarily explain the underlying cause. It just is the cause in that logic.
Precisely. And the book also raises questions about certain diagnostic categories like personality disorder.
Okay, yeah. What's the issue there?
The critique suggests that maybe labeling someone with a personality disorder is sometimes just a way of categorizing behavior that society finds, well, difficult or maybe morally questionable. It argues it might not offer a deep understanding of why the person acts that way. It highlights the vagueness and the potential for these labels to reflect social judgments more than objective pathology.
And then there's adult ADHD. The book uses this as a kind of case study, doesn't it? As maybe a constructed diagnosis. You hear a lot about this now.
Yes, it's really striking. Adult ADHD as a widespread diagnosis really only emerged in the 1990s.
Right, it felt like it came out of nowhere for adults.
Kind of. And while sometimes it's seen as childhood ADHD carrying on, it's increasingly diagnosed in adults who never had that label as kids. Plus, the diagnostic criteria are pretty broad.
Like what?
Things like forgetfulness, being easily distracted, difficulty getting organized. Stuff that, let's be honest, a lot of people experience sometimes.
Yeah, I mean, who doesn't struggle with focus now and then or lose their keys?
Exactly. And the treatment, especially the common use of stimulant medications, that also raises some big questions in the book.
How so? The stimulants.
Well, it's notable that the main treatment often involves drugs that are, a prohibited class for recreational use, stimulants.
Right. Speed, essentially.
And there are known issues with these drugs being diverted, sold, or given to others, and the potential for addiction isn't trivial.
Okay.
On top of that, the book cites research questioning how effective these stimulants really are long-term for both kids and adults. Do they actually lead to sustained improvements in quality of life or, say, school performance? The evidence is apparently not as strong as you might think.
So questions about the diagnosis itself, the treatment, the long-term effects.
Yeah, it's a complex picture.
And it's not just ADHD, is it? The book also looks critically at the rise in bipolar disorder diagnoses.
That's right, especially the widening of the category to include the bipolar spectrum and, perhaps more controversially, pediatric bipolar disorder.
Diagnosing bipolar in young kids. I remember hearing debates about that.
Exactly. It raises concerns about potential overdiagnosis and maybe overly aggressive medication, especially in children. Historically, true bipolar disorder was thought to be extremely rare in kids.
And is there discussion about why this expansion might be happening?
The book does touch on potential influences, mentioning figures like Joseph Biederman and his research funding, suggesting that pharmaceutical interests might have played a role in broadening these diagnostic boundaries.
Okay, so the influence of the drug companies potentially shaping how we even define these conditions.
It's a concern that's raised, yes. And even the term mood stabilizers, the book suggests that category has a bit of a fuzzy history.
Really? How so? Depakote is mentioned as an example.
Yeah, Depakote is a key example. The idea of mood stabilizers really took off with its marketing, even though there wasn't perhaps a super clear scientific definition of what that meant or how Depakote supposedly achieved it.
So the marketing kind of created the concept.
Well, it certainly helped popularize it. Sales went way up based on this somewhat vague notion of tackling mood instability, the idea that it was fixing some biological problem with emotions. But the evidence for that specific mechanism, and even its long-term effectiveness, was apparently weaker than many believed.
Wow. So diagnoses expanding, maybe sometimes faster than the science, treatments becoming widespread. It raises that bigger question you mentioned. How does all this medical framing play out socially and politically?
Exactly. And Demedicalizing Misery, too, really digs into that, looking beyond just the individual.
Where does it go with that?
It gets into what's called the politics of recognition and this broader therapeutic culture.
Okay.
The argument is that focusing heavily on individual therapy and recognizing individual trauma can have these unintended side effects, like potentially pathologizing whole communities based on historical trauma or encouraging this therapeutic sensibility where almost every social issue gets viewed through a lens of psychological damage and healing.
Right. And there's this concept mentioned, the damage theory of personality.
That sounds intense.
It is. It's the idea that historical victimization, like, say, the legacy of slavery or other forms of systemic oppression, can cause lasting psychological harm, leading to something like collective low self-esteem across generations.
Okay, I can see how that might be argued.
But the book raises concerns. Does this view end up essentializing identity? Does it inadvertently lower expectations for those groups? Does it risk reinforcing problematic stereotypes?
That's a really tricky balance, acknowledging historical harm without defining people solely by it.
Exactly. And there's also a critique about exporting Western therapy ideas globally.
How so?
Well, applying Western concepts of trauma, recovery, and the self to other cultures risks. Again, pathologizing people and maybe even reviving old colonial ideas about certain groups being inherently damaged or fragile.
So the therapy designed to recognize suffering might actually encourage people to identify too strongly with being victims. That's the potential downside explored, yes. That identities based on past misrecognition might become kind of stuck in their suffering, making it harder to move forward.
So it's not just about individuals, but how whole groups understand themselves and their history and how therapy interacts with that. Okay, shifting gears slightly, the book also talks about language, right? Discourse and how we categorize things.
Yes, this is crucial. The idea is that both everyday ways of talking about psychological stuff, what we might call lay accounts, and the professional psychiatric language actually draw on the same shared cultural toolkit for sorting people and making moral judgments.
So it's not like psychiatry has this completely separate objective language that just describes reality.
The book argues, not necessarily. It suggests that scientific psychiatric labels don't just arrive fully formed and replace everyday understanding. People have always had ways of understanding the psyche long before formal psychiatry.
So our everyday understanding isn't just waiting to be corrected by science.
Exactly. The book argues it's more important to describe how people actually categorize themselves and others in real life, in their interactions, rather than just focusing on the official scientific explanations. It questions some of the basic assumptions of the whole psi complex.
Psychomplex, you mean the whole system.
Yeah.
Professionals, institutions, the knowledge they create.
Right, that whole network. And it gives some really interesting examples of how people who get labeled with things like learning disabilities or mental illness actually deal with these labels day to day.
Oh yeah, like what?
Well, using interview data, it shows how people actively work to manage these identities. Someone might really emphasize being a worker, for instance, to push back against the idea that their diagnosis makes them incompetent.
Trying to present a different side of themselves.
Exactly. Or they might use family members as sort of witnesses to prove they can handle ordinary things like crossing the street safely, to counter assumptions that they're irrational or incapable.
Wow, it really shows the power dynamics, doesn't it? The constant need to prove your competence when you've been labeled.
Absolutely. It highlights the scrutiny people face and the constant active work involved in presenting yourself as ordinary when society might see you as deviant.
Okay, so we've talked about diagnoses, treatments, the social impact, the language. We can't really avoid talking about the role of pharmaceutical companies, can we? Demedicalizing misery second goes there too.
Oh, yes. It discusses the major influence that drug companies can have on expanding diagnostic categories and pushing drug treatments.
Why? What's the driver?
A big part of it is the product patent system. Companies need to make back their investment and make profits, which incentivizes finding new uses for existing drugs or developing blockbuster drugs for large markets. This can create pressure to define more conditions as needing medication.
Find more problems for their solutions, essentially.
That's one way to put the concern, yes. And the book also critiques the gold standard for testing drugs, the randomized controlled trial.
Really? I thought those were supposed to be objective.
Well, they are intended to be, but the book argues they have limitations and can even be, well, manipulated. How data is analyzed, what gets published.
How so?
For example, sometimes statistically insignificant results are used to dismiss potential risks or side effects. The early reports linking Prozac to suicide risk being brushed off as just anecdotes because they didn't reach statistical significance in trials is given as an example.
So serious potential harms might get downplayed because they don't happen often enough in the trial group to meet a certain statistical threshold?
That's the concern raised. It paints a worrying picture of how financial motives and the way we use statistics could potentially hide the real risks versus benefits of some psychiatric drugs.
And the book even talks about the doctor-patient relationship in this context.
Yeah, it mentions this idea of a kind of Stockholm syndrome where patients might develop such strong trust or dependence on their doctor and medication that it becomes hard to question the treatment or report bad experiences. And it also notes that it can be increasingly difficult for doctors themselves to speak out about potential drug harms, perhaps due to various professional or industry pressures.
Okay. And then there's a really fundamental point the book makes. Even if there are biological differences between people,
Yes.
is it right to automatically label those differences as disorders just because they're less common or because they make it harder to fit into society's current structures?
This is such a crucial question. Are we medicalizing difference itself? The book suggests we need to be really careful about confusing statistical rarity or difficulty conforming with an inherent medical pathology.
So just because something is different doesn't automatically mean it's disordered.
That's the core argument there. And to provide a bit more historical backdrop, Demedicalizing Misery 2 also touches briefly on how the diagnostic manuals themselves, like the DSM, have changed over time.
How have they changed?
Well, the book points out a general trend of broadening the criteria for existing disorders and adding many new ones over the decades. This has massively contributed to the expansion of what's considered mental pathology.
More things are classified as disorders now than before.
Essentially, yes. And it contrasts earlier approaches like in the first DSM, which might diagnose a depressive reaction clearly linked to a specific life event.
Okay, context mattered more.
Exactly. It contrasts that with later versions like DSM-3 introducing major depressive disorder, which focused much more on a list of symptoms regardless of the context. This shift arguably made it easier to medicalize what might be considered normal, understandable distress in response to difficult circumstances.
Interesting. Now, there's another really compelling part of the book that offers a different lens for understanding some severe mental health issues, like psychosis. It brings in trauma.
Yes, this is a powerful section. It highlights the growing mountain of evidence linking adverse childhood experiences, abuse, neglect, bullying, household dysfunction, to a significantly higher risk of developing psychosis later in life.
We hear more about the ACE's studies now, the adverse childhood experiences.
Exactly. The book cites statistics showing just how much higher the risk is for people with that kind of trauma history. It's not a small correlation.
So suggesting a psychosocial pathway rather than purely genetic or biological?
Precisely. And it introduces the concept of dissociation as a potential bridge here.
Dissociation, like feeling detached.
Yeah, think of it as the mind's way of coping with overwhelming, unbearable experiences by mentally disconnecting. It's a survival mechanism. But the idea is that severe or chronic dissociation triggered by trauma could manifest in ways that look like psychotic symptoms, like hearing voices or having profound disturbances in thought or perception.
So what gets labeled as, say, a first-rank symptom of schizophrenia might actually be understood as an extreme, stress-induced dissociative experience rooted in trauma.
That's the alternative perspective being explored. It offers a psychological and social explanation for experiences often viewed as purely biological brain diseases.
That's a profound shift in thinking.
It is, and the book also briefly mentions things like insecure attachment patterns formed in childhood and the field of developmental traumatology, how early trauma shapes development as further support for this more holistic view.
Okay. So, taking all this together, diagnoses, treatments, social forces, trauma, where does demedicalizing misery to leave us? What's the final takeaway on suffering?
Well, it really circles back to the idea that suffering itself is fundamentally subjective. It's not really a scientific category.
Right. How I feel pain is different from how you feel it.
Exactly. And crucially, whose suffering gets noticed, gets attention, and is deemed to require treatment often isn't about the intensity of the suffering itself, but about social factors. Power, context, how visibly someone expresses their distress.
Can you give me an example?
The book uses contrasting scenarios. Imagine a wealthy, powerful person experiencing distress versus, say, a young, isolated mother struggling to cope. Their social position, their vulnerability, how they enact their suffering publicly can lead to vastly different responses, including whether or not professional intervention happens.
So, social standing and how we perform distress dramatically influence whether it gets medicalized.
That's the argument, and it leads to a final, quite provocative thought about psychiatry's claim to special knowledge.
What's that?
The suggestion is that psychiatry's assertion of having this privileged, abstract, scientific knowledge might sometimes obscure a reliance on everyday practical wisdom, while not fully grappling with the bigger social and political forces that actually generate so much distress in the first place.
So maybe it claims too much scientific certainty while not adequately addressing the societal roots of the problems it tries to treat?
That's the challenging question it leaves us with. It pushes us to question the limits of psychiatric expertise and to think more broadly about how we understand and respond to human suffering.
Wow. Okay, so just to recap, we've really dug into this shift towards medical explanations for unhappiness, the serious questions about diagnostic validity and treatment effectiveness for some conditions, the huge role of social and political factors, and these alternative ways of thinking, especially around trauma and dissociation.
Yeah, it's a lot to take in.
It really is. This deep dive into demedicalizing misery to second and the other sources definitely makes you think critically about the stories we usually hear about mental health and well-being.
Absolutely. And it leaves us and you with a really vital question to ponder. What are the real-world consequences of seeing distress, mainly through that medical lens?
Right. What do we gain? Maybe easier access to certain kinds of help, but what might we lose?
Yeah, what gets lost by maybe overlooking the wider social context, the psychological impact of life experiences, the historical factors? Are there other ways we could be understanding and responding to human suffering?
Definitely food for thought. We really encourage you to check out these sources if this sparked your interest and keep asking these important questions.